Thank you, Helen. So welcome everyone to the Roundtable, the CRA-Industry Roundtable on sharing healthcare data. My name is Devesh. Um, I'm at AT&T as part of my day job, although I guess it's still daytime, so this is still part of my job. And I'll be the moderator for this interesting panel on sharing healthcare data. So let me just start by introducing CRA-Industry. Helen, will you be moving the slides or should I share my screen instead?
I can move the slides if you want to let me know.
Sure. So we'll move on to the next slide. Okay, so this is an overview about the CRA industry. So CRA is the Computing Research Association, as many of you already know. And CRA Industry is the latest committee, the most recent committee of CRA. And the mission of CRA Industry is to convene our industry partners on a variety of computing research topics and connect them with the people, both the people from industry as well as our partners, to make sure that we have good societal outcomes. So CRA, as you know, have this nice triangle between industry, academia, and government, and CRA Industry sort of looks at this triangle from the perspective of that industry node. And who we are we're trying to represent companies, industry of all sizes, um, ranging from big corporations to small startups, but also across the entire spectrum of computing research, not just the ones that are considered traditional computing. And in fact, today's topic of today's roundtable, healthcare, is something which you can think of as something which has become very computing intensive in recent years, but is not considered a traditional computing industry the way many computer scientists think about it. And CRA Industry, over the years, the 2 years or 2.5 years of its existence, has been convening members to share perspectives. And we've been coordinating with other CRA stakeholders as well. And we've been doing this by interviewing people one-on-one, then convening small roundtables of this kind that you see, often followed up by day-and-a-half-long in-person workshops. The output of what we do is to produce white papers and reports. And eventually, we'd like to be able to get to things like public-private partnerships that can then carry forth our agenda forward. Helen, if you'd like to move to the next slide, please. So today's roundtable focuses on healthcare, and we would like to discuss the challenges of sharing healthcare data, right, and the opportunities in different settings, within academia, within industry, possibly within government as well. As some of you know, one of our panelists, Belinda, was from NIH. She was going to represent government, but unfortunately she had to cancel at the last minute because of a family emergency. But despite that, I think Tammy has stepped in, and I think it's going to be a very interesting roundtable. We're going to try to sort of identify solutions as well, and what are the next steps in this space. Next slide. So I expect, when we start the discussion in the panel, our panelists are going to tell us what are the range of possible things that are about healthcare. So this slide is not particularly about healthcare, but it's a slide that I sort of borrowed from a recent article I saw on some best practices for sharing research data in general, right? I won't go through all of these issues, but the topics are, for instance, these slides will be available to people later on if you would like to sort of look at them. And so all of these issues around making sure that you have good quality data, right? It's, you integrate them properly. You sort of collectively develop these strategies. These are all important things in the context of any kind of research data. And we'll talk next with our panelists about what is interesting, what is special about healthcare data. Okay, so let me now introduce briefly our panelists. If you move to the next slide. Okay, so we already talked about the welcome and a CRA industry overview. This is going to be about the discussion. right after this, so this will be for about 1 hour, think, and then we'll have adequate time for taking questions from the attendees from the audience. And in terms of logistics, your Zoom session has a Q&A, right? So please type in your questions in the Zoom Q&A. And after our initial panel discussion, I'll be asking questions to the panelists. And towards the end, depending on how people are interested, you may even raise your hand and we could admit you to the panel so we can have a more open, free-for-all discussion as well. Okay, so note that this event is being recorded and will be posted on the website. Next slide, Helen. So we have three very accomplished panelists here, specialists in the topic of healthcare. So first is Margarita Gonzalez. Margarita is at the Georgia Tech Research Institute. I won't tell you more about her because later on I will ask Margarita to introduce herself and talk more about it. Then John Kansky. I don't know why the Y is missing, but maybe that's in it itself. So John Kansky is at the Indiana Health Information Exchange. And Tammy, who until yesterday was one of my co-moderators, but now is as a panelist. So Tammy Toscos is in Parkview Health, and she's also a member of the CRA-Industry Council, which is the organization that is hosting today's event. So the next slide will just give you a hint about the kinds of questions that we would like to ask. But rather than leave the slide on the recording, what I would like to do, Helen, is if we can just stop sharing so we can see our panelists in full screen mode so we can have an open discussion. And just fortunately, Tammy has managed to connect to video and audio just at the right time. So welcome, Tammy. So let me just start, the questions here. So for each of the panelists, right? And what we'll do is, for the first question, we can start with Margarita, go to John, and then conclude with Tammy. Tell us something about yourself and your connections to the healthcare domain, and what does sharing healthcare data mean for you, right? What do you think are the interesting aspects of healthcare data? Why is sharing healthcare data so important? Right? As a computer scientist, I would say many of us know that data is central and it's something that enables a lot of science, right? But from the perspective of healthcare, I think we would like to listen to your thoughts. So Margarita. Margarita, you're on mute right now.
Thank you for that, Devesh. Okay, can you hear me now?
Yes, very well.
Great. Okay, I try to jot down all the different questions and sub-questions, so I'll do my best, Devesh. Okay, thank you. Thank you again for the invitation to join you guys for this panel. I'm really excited for the discussion. Already was excited just to kind of ideate some of these questions and whatnot. I will say, so I'm not a computer scientist. Kind of give my caveats for now, so because it'll give a context for the rest of my answers for the rest of our time today. So I'm at GTRI. My role here is I'm a principal researcher as well as a senior technologist for digital innovation. So let me translate what that means. In my capacity, I lead social technical teams in the research, design, and development of human-centered solutions. Basically, our emphasis is on the integration of diverse research aims. And so we are looking at this from a more applied research perspective. The other thing I want to specifically call out for the discussion is, while I'm not a computer scientist, I am a social scientist. And so I'm coming at technology as originally not a technologist. And then I've been here almost 17 years now, so I've become one. So really, a lot of the work that I have done and what I'll glean from in my examples for today are from the public sector. So while I am at GTRI, Georgia Tech Research Institute, which is a university-affiliated research center, we are academic, but we also do actual sponsored research on large programs for the Department of Defense. And so a lot of my perspective has been colored through that. But even, John, when you were talking about some of the people that you know here at GTRI, I have been very involved in the past with Georgia Medicaid and some of our healthcare providers here in the state of Georgia, as well as even with the CDC, which is down the hall from us, or I say down the hall, down the street from us. John Duke is down the hall from me. And so the question that you've posed to open us up, Devesh, is what does it mean to share health data? Well, in my context, in the context that I've been working in, it's really more around military psychological resilience and readiness. And so I want to emphasize, while we don't always think about, or maybe in the past haven't thought about psychological resilience as being related to health, it absolutely is, especially in the context. Definitely during, I mean, I think that was brought to our radar, if it wasn't already, during the pandemic, right? It's the key and the importance of psychological resilience, mental wellness, and health for overall health, right? And those of you who have been in healthcare know this. And I guess I should also mention that in a previous career, I was a diabetes educator and worked with people of Black and Brown communities, working around, their very much their health, but lived and saw how it impacted their mental wellness. So I've seen both sides. And in the military, interestingly enough, actually, now they're having this conversation of thinking about all different dimensions of wellness and health for the purpose of, obviously, the service member and their families being resilient and being ready. So for us, sharing data, we think of the unconventional data and how it matters for looking at that holistic picture. So some of my comments will be around that. But I just want to be more explicit about what I mean by data. So for us, it's been working with enterprise legacy systems, both dealing with structured, unstructured data, survey, and self-reported data. And so as you can imagine, just from that short list, very diverse types of data generated by very diverse groups of people. And that is very important because that gets absolutely reflected in information management behaviors. And then on the data sharing aspect, while I think traditionally we think of it as it's an essential part of, living and working in the digital world, it really is fundamentally, and this is me, the social scientist speaking here, knocking down functional and organizational silos. Because it's not just a data and a technical problem. It absolutely is a reflection of some of the things that have not been addressed and need to be addressed from a cultural and organizational perspective, meaning more explicitly requiring clear processes, policies, and pipelines. So that's what I'll say for now. Thank you.
Thank you, Margarita. John, so we heard from Margarita about the range of different kinds of data she thinks of as included in healthcare data, right? But it's a very vast, of course, and maybe you have some additional perspectives on what healthcare data means to you. But before that, just tell us a little bit about yourself too.
Sure, thank you. So John Kansky, I am the CEO of the Indiana Health Information Exchange. If you know what an HIE is, great. If you don't, it's a not-for-profit organization that operates a statewide data sharing cooperative in healthcare in the state of Indiana. So if you can just imagine most stakeholders in healthcare, whether that be hospitals, doctors, insurance companies, public health departments, my organization gets up every morning, works every day to share healthcare data appropriately across that ecosystem. So I'm an engineer by training. I also have an MBA, but any technical knowledge I had became irrelevant probably 5 years ago. As the CEO, I'm more of a strategist, small p politician, occasional salesman, et cetera, diplomat. But it is a very interesting business to run. Earlier in my career, I was a HIPAA consultant, if you know what HIPAA is. Before that, I was a clinical engineer in a hospital setting for a number of years, and I call on both of those experiences frequently. I like the question, what does data sharing or health data sharing mean to you? Because I've said in many public settings that I can tell you the day and the hour and where I was when I decided that I wanted to work in health information exchange, which is essentially the business of sharing data, sharing healthcare data, because in December 5th, 2005, I was at a conference where they were talking about what was then called local health information infrastructure, which is an old term, but it's the recognition that especially in those days, healthcare system was very fragmented and siloed. And while we've made tremendous strides in terms of standards and electronic health records and the ability to share between them over the last decade or two, many of us from our own experience, you may be thinking this right now, is, well, based on my experience in healthcare, you haven't completely solved the problem, Mr. Kansky, because my lab result wasn't at the doctor the last time I needed it, or my aunt had a delayed surgery because they needed information they didn't have, et cetera, et cetera, et cetera. Or just talking about the compliance to the response to the pandemic in the last couple of years, and the many, many failures of information, lack of information, some of which was due to a lack of sharing, some of which was due to the fact that the information didn't exist, or the system to capture it didn't exist to begin with. So pretty much the last 20 years of my career has been all about sharing healthcare data.
That's fantastic, John. Tammy, welcome. And, I know you were originally supposed to be on this side of it as a moderator, but now you'll be answering questions instead of asking the questions. But, I would like to mention that this roundtable on sharing healthcare data began because of Tammy's interest on this topic, right? So Tammy, tell us, more about yourself, Parkview Health, your role in this, and your thoughts about what varieties of healthcare data do you encounter that have, maybe some of it overlaps with what Margarita and John have mentioned, and others might be things that complement that.
Yeah, thank you for that welcome. So my name is Tammy, and I have a very unusual role actually at Parkview Health, which is a fairly large healthcare system in Northeast Indiana. I was invited to start a lab there about 10 years ago in health services and informatics research. Prior to that, I had taught in computer science, and I actually also taught in the nursing school briefly. And I do have a degree in computer science. I really consider myself more of a health services researcher at this point in my career, but definitely use a lot of computing in my lab. We have 22 people on my team, trained in 15 different fields. We're very interdisciplinary. We're embedded in the health system, so we're doing a lot of projects for leadership and with clinicians, which gives me the real world view of how difficult it is to really make meaning out of some of the data that we're presented with. And we also do a lot of work in the community. So we work with a different kind of health data, public health data that we're integrating, and along with qualitative data that we collect. So I feel like even in the Zoom meeting, I'm right between John and Margarita, and I feel like that's really where the work in my lab sits. Is we do use a lot of electronic health record data. We depend on it a lot for research, but more for the sports health system. But in our core research areas, we really do a lot more social science type work. We have a strong focus in human-centered design, and we have some people who have expertise in social computing and even use social media data as a healthcare data. So there's a really broad spectrum, and I think for me, sharing healthcare data is multifaceted. If I have my research scientist hat on, it's about being able to work with our university partners effectively so that they can train students and we can share data with them so they can progress their research portfolio. When I put my health system leader hat on, I'm really thinking more about how can I translate this very complex data into information for decision making. And we did a lot of that during COVID, actually, where we were using a combination of public health data plus our electronic health record data. We developed models to help our leadership team make decisions about resources in our health system. So that's why I'm so fascinated by this. I think the other type of health data, I don't know, maybe Margarita mentioned this, are on-the-body sensing devices or implanted devices that have a personal health data. That is something my lab works with as well. That's more kind of very laser focused on the individual who's contending with a disease or managing their health. So I guess I hit a lot of spectrums on data, and I'm excited to finish out the questions with you, Devish. Thank you.
That's wonderful, Tammy. So let me start off with some of the technical questions. And the first question I have is actually even related to one of the questions that got posed in Q&A. Right, so we have seen that sharing data often requires sort of standardization, right? Wants to make sure, when you share data that you have sharing high quality data. Otherwise, you run into this garbage in, garbage out kind of, scenario. So can we sort of think about, can you tell us a little bit about how you have been addressing issues like standardization, making sure you don't end up with too much missing data, or address the data quality issues that exist? Maybe John, we can start with you this time, and you can tell us about this from the perspective of what you have seen.
Sure. How many hours do we have?
We have until infinity.
Yeah, data quality is huge, and some caveats to make sure I'm making sense and not skipping any algebra for this audience. Remember that my perspective is that we're running a data cooperative, so we have many different organizations sending us data from their working systems in standards, meaning there are absolutely standards, and what they send over is an attempt to conform to those standards. And also, if you're getting data from a health insurance company, a public health department, and a hospital, it's going to come in different standards. And none of it conforms exactly to those standards. And importantly, for any researchers who are listening, because it's an incredible frustration for researchers that the data that you get from the real world is a mess. The real world is a mess. Our
John,
primary...
if I can interject, are you saying that the data accurately reflects the real world because the real world is a mess?
I think I'm saying that not only does the data reflect the real world, which is a mess, but the data is a mess on top of that. So that is to say that, well, let me stay on the path that I want to make the point that our focus first and foremost is support the treatment of patients. And so if you've got 22 records from different sources about that patient that can be distilled into something that helps a doctor, even if it's got some warts or some missing fields or stuff in the wrong place, if it helps, it helps. So when that data is accumulated and aggregated across the population in a way that can support research, now we have sort of a different lens. And we have to say, how can we distill, and in some cases double distill, that data to make it useful for research?
Thank you, John. Margarita, you have been talking about using data for the purpose of the military. How have you seen sort of this role of standardization, data quality, and others sort of impact in terms of how data affects the military?
Yeah, so I'd like to, this is an excellent question, and I smile because I mean it's going to be a situation that has to be addressed no matter if it's health data or not health data, right? And with the military, they own all their systems. They're not sharing with for the cases that I'm looking at, or what my context, with outside providers, and even then it's a mess. So it just is. And so what I would like to highlight as a social scientist is that a lot of these systems, especially the legacy systems, and even some of the newer systems, what they reflect are processes that were in place at the time, right? And use cases that needed to be, or uses that needed to be documented, interactions that needed to be documented. So it all made sense at that time. It's just that things evolve and their processes have evolved, and they, you have a situation where, those of us who work in AI or work with AI people, there's always this whole thing about model drift and data drift and all that. Things drift. That's just what it is, right? So in terms of how we address it, I don't even act surprised anymore. I don't even try to hide my surprise. It just is, right? So what are we going to do to work with it? Well, so what I would propose, and I actually had a stint, one of the very first projects that I led at TRI, John, was actually with the Georgia HIE, when Georgia decided to roll out their federated HIE and whatnot. And so the reason I bring that up is because I see some parallels here, right? So organizationally and with people, so kind of agree on what is, if you're wanting to tackle things together, what are those, whether it's an analytical use case or just a use case, understand what it is that you're trying to get at. And at least in the context of the military, we have had great success in just having those conversations prior to jumping into, okay, what do we do to the data for research purposes? And you're right. I'm so glad, John, that you made the distinction between, are we talking about for the use of delivering services, or are we talking about for the use of research, right? Because those are very distinct. At some point you want them to intersect, obviously, but you need to be very super crystal clear what you're talking about to begin with. Otherwise, it's really, you're not going to make a lot of progress. It's going to be very frustrating. The other thing is ensuring that you have the right perspective. So, you know, at least for us, and it's always disappointing when it happens when you ask for the documentation of where the data originated, right? And you don't have it. So now trying to piece it together, that's a challenge. So there are some tactics, and I don't know if for this question you want me to go into what we've done to standardize some of that data once those clear use cases have been identified, not before. But I also, before I get your hopes up, when we work with the military and the specific things that they bring us on for are for help us with what essentially is data engineering problems. So if you guys aren't familiar with the data science hierarchy of needs, you know, it has been very helpful for us in speaking the same language, because what people want are these sophisticated ways of manipulating data, which is higher up the pinnacle of the data science hierarchy of needs, but yet no one really wants to spend the time nor the energy to tackle the time-intensive, labor-intensive data engineering problems, right? And so for GTRI, that's why I don't want to get your hopes up, they are paying us to address those issues, and with the hope and, you know, expectation that we're climbing Mount Everest, right? So we tell them it's Mount Everest, but at least, you know, now we're clear, right? And so there are tactics that we use, and this is over time, over months, you know, and we have had great success in helping them standardize select data sets for very clear documented use cases.
So Margita, you sort of alluded to, you know, you have certain strategies that you have tried, right? And there's probably a lot of them, right? So, you know, we can probably spend a lot of time talking about them, but maybe if there is one strategy which has stuck out in your mind as something that has stood the test of time.
Well, so one thing that we did at the very beginning when it was a big mess, since we have John talk to us about messes, and some are very large, like multiple years. I'm talking about some of these systems are used across the world. We're not just talking about one site, across the world, across military communities. So if things go awry, it's an, oh my goodness, what do we do now? So, okay. So we have to be conservative, Devesh, okay? And so basically it's identifying, okay, one application, one workflow, but know that it's high value data, okay? And propose, how do we re-engineer the workflow and it be reflected in the application, right? So that's for data to be collected. What do you do about data already collected? Because we want to use that as well, right? So there are things that we have done, again, working with the clinicians and the researchers and the social workers and the whatnot to figure out, okay, how do we do surgery on historical data for this in the context of the workflow and the application that you've identified? And then moving forward, how do we ensure quality data capture moving forward? Because that's easy peasy once we define what it is that we're trying to do. The historical data aspect is a little bit, it is messy. That is very, very messy. And that has been a little bit of data transformation, a little bit of like, okay, let's look at the data tables. What are we joining? Because at times what they really want is to combine diverse data sets, right? Which if anyone has done that, you know, it's a problem. It's a challenge, especially if the data is already captured. So you want to be proactive. We learn from the past. So where we can, we've done surgery on what already has been captured. And then moving forward, we just really overhaul the application while still preserving the operation of a large system that thousands of people use. So we have done that. And we have those. Now that things are in the cloud, there's a lot of things that are available to us. So that's one example. The other example, and I have mentioned this to a brief conversation that I had with Tammy a long time ago, couple months ago, around data-centric AI. And so probably a lot of the people in this audience, from some of the things that people that you said anticipated joining, are familiar with data-centric AI. And why, again, I'm not the engineer, so you don't need the details to come from me, but why we have been exploring this is because for things where they are primed for exploration of AI, maybe they don't have a lot of data. And you don't want to be beholden to crafting a model that is going to need a lot of data. And by data, we're talking about diverse data. We're talking about representative of data. Like there's a lot of attributes to the data. So you don't want to put, and also the compute power that's not always available. While the military is vast, you got to think about they're providing services in places that are pretty remote sometimes, right? So we can't be dependent on an infrastructure, and I'm using that word loosely, that requires high compute, right? So we are in a lab, but also experimenting, thinking about, okay, how can we do this, safely, and thinking about it, okay, once we prove the concept, okay, now let's think about how do you integrate it into an operational system, because that's a different challenge, right? So again, part of that is let's fix what we can right now with the data that they have right now. But moving forward, you're going to need different data. So let's think creatively about that, right? And thinking about as we are enhancing your application, your system, we're future-proofing it so that, because you're going to find yourself in this position again, right? Like it just is. And so a lot of it is more about, and I did have a comment to myself, it really is about the clinicians working more closely with the, creating an environment where the people who are doing the analysis and the data science, the data engineers, the system designers, the clinicians, but in our role, in our organization, we're able to do that. Not everyone has that ability, and I get that. That's why I don't want to get your hopes up. But that's the kind of work that we do.
Thank you, Margaret. But you raise a very important point about sort of dealing with legacy data and legacy processes, right, as things evolve and drift, right? So Tammy, sort of mentioned that, she sits logically between Margarita and John. So maybe, Tammy, you can sort of bridge some of these things from your perspective and see what are the interesting ways in which you have addressed these issues around standardization, data quality, right? And Margarita, the topic of AI will come up again shortly, so we'll sort of pick that up again.
Okay.
Yeah, I think my best example of dealing with really difficult data did have to do with COVID times. So as a research team, we were called upon by the health system to just help facilitate that decision making on resources. So it was really important for us to understand, how many COVID patients were going to be in the health system at any particular time, to understand staffing. At one point in time, we were worried about, the number of ventilators we had, if you kind of remember those times. So we started off looking at a lot of different ways of predicting this. One way is looking at the numbers. So the state of Indiana was reporting the numbers of COVID positive tests in our communities, and that was available online. So we were scraping that data from, I think it was the New York Times was our source of data at that point. So we were just like Rambo. I don't know. We were just like cowboys, just going out there trying to find whatever data we could. We were using epidemiological models. They were not sufficient. So we have very, very talented data scientists who developed a local predictive model that leaned on our electronic health record data. And I really had never worked with electronic health record data as much as I did during that time. And we were finding a lot of issues with, for example, just even how we were counting the number of COVID patients when compared to some of the other business units in our business. So we have a business intelligence unit. We have that was under IS, and a finance department. And so everybody is looking at these counts from a different lens. And this really turns out to be a big thing in healthcare, because if you're in finance, or if you're a clinical person, nursing, or you're inpatient, outpatient, you're looking at all of these these same data, or what you call COVID patient admissions, in a different way. So our numbers tended to be higher because we were looking at patients who were admitted with COVID until they were discharged. Whereas for the infectious disease folks in our health system, they were looking at as soon as that COVID flag, so as soon as the person wasn't COVID positive anymore, they came off that list of COVID admissions. So for the people we were working with, it was important to see that whole time period of a patient being admitted, because that's the resources were still very high for that patient. And so this is all what we would call data governance in the health system, and it proves it. Length of stay in the hospital, for example, has multiple definitions within our health system, and I had really no clue. And I grew up in healthcare. I grew up, my first job, I worked in the VA system. I was part of the beta testing for the first electronic health record in the VA. And I felt like I understood what electronic health record data was. But it turns out, like I think Margarita said before, like the policies that you have in place around these things are really important. And sometimes there's social things around it as well. So that's having that social science lens on it and understanding that you have a lot of different roles within the health system or any system that need to understand data in a different way is really important, and having like that kind of respect for other people's need for that data turned out to be really important. So I would say that the way we overcame that was using our human-centered approach to understanding problems, where we really were talking to the end user of, we were generating slide decks every week for different leaders. We really tried to understand what they needed. And then we used our scientific minds to really question the data. Like, is this really right? And we were doing a lot of manual review. That is probably not a great strategy. And John probably has a lot of better ways I can learn from. But, we were just, at that time, we didn't know what else to do. And we had our team manually reviewing COVID patients' records to validate that they indeed were COVID patients, that if they passed away, that they did die of a COVID-related illness. And we were doing all that sort of manually for a couple of years. So that's not a great strategy. But the human-centeredness of it, I think, is one of our key strategies.
Thank you, Tammy. John, I saw you raised your hand. You wanted to add something?
Yeah, I wanted to, taking advantage of Tammy's example to demonstrate challenges with healthcare data and healthcare informatics. If you think about counting people who were in the hospital for COVID during the pandemic response, and early in the pandemic, okay, we're counting the people who are coming to the hospital because they have COVID. How are the doctors figuring out they have COVID before there was good testing or diagnosis, whatever? Now, move later into the pandemic, and you're watching the trend of this graph and trying to make decisions based on it. At some point, the hospitals have lots of testing capability, and they're capable of testing everyone, and they are testing everyone who shows up for appendicitis, for a knee replacement. They're testing anyone who's coming to the hospital. And if they test positive for COVID, guess what? They count them as a person in the hospital with COVID. They weren't admitted to the hospital because they have COVID. How do you separate those two things, because they're very different? I just wanted to offer that example.
Very good insights. Let's move on, so from beyond sort of the aspect of what happens when you sort of collect the data and the data quality issues to when you use the data. We've all heard a lot about ethics in use of data, right? Concerns about making sure that the data is used ethically, but also, making sure that the right consent is received from the data owners, right? So in the context of the healthcare data that you have been looking at, talk a little bit about, who do you think is the owner of data? Who do you need to get consent from? How do you make sure that the data gets used only for, maybe the research that the person is willing to continue with? So all the issues surrounding the ethical use of data, right? I think healthcare data is a prime example with many of those issues might come up. So maybe John, if you would like to continue on your thoughts in that on that vein. You're on mute, John.
I'll try to keep it short, but this is another deep topic, and we can go in any direction you like. We have to operate as a health information exchange who's taking, accepting. We don't own any data. We are the stewards of other organizations' data. That's point number one. Point number two is when you answer the question, who owns the data, there's the philosophical answer and there's the Indiana state code answer to that data. So the answer to who owns that data in Indiana might be different than in other states because they treat healthcare records in Indiana as being the property of the organization that originated that record. Now, if I say, well, that data belongs to the hospital, a person who's an advocate for patient transparency or what have you might say, well, that's the patient's data. That's a philosophical statement. Okay, so let's just acknowledge that difference that needs to be acknowledged. In terms of the ethics or the appropriateness of sharing, we absolutely, it's paramount in our business. And we have this fairly, if you look at it, there's sort of this ecosystem of framework and legal structure and consent and contracts that govern this whole process. Now, this is my world, and I don't necessarily expect everybody who doesn't understand health information exchange to track what I'm saying, but to make it more simplistic, if you run a data co-op, no one's going to share their organization's data with you if they don't feel secure that data is going to be handled appropriately. They will understand what uses are permitted and not permitted, and that will be written into the contract. There's a governance process that can dynamically over time determine if the rules are going to change or be adjusted or expanded or tightened. You've got a layer of federal regulations that change over time. You have state regulations that can change over time. If you want to do something more interesting or special, maybe the data is special, like drug abuse data is in a specific category of data. Psychotherapy notes are in a specific category of data. And then even, and all that's the subset of HIPAA protected in a larger Venn diagram of HIPAA protected data. And so when you go to do treatment, the rules are different than if you go to do research, and the consents are different if the data is identified versus if it isn't. So all I'm trying to do is lay out the kind of the complex ecosystem.
Right. So thank you, John, for doing that. Let me ask Margarita, right? Margarita, you mentioned that, in your context, you might be dealing with, sort of a more sort of a closed system where, the data doesn't necessarily leave the system and so on. But do you encounter these challenges around the ethical use of the data for AI or other kinds of analysis or other kinds of treatment?
So I'll pick up where John just left off. I think for us, it's really around the original intent. That's the issue, right? So data was originally collected for, say, for example, really squarely service delivery or an intervention. And now it wants to be used. They want to use it for health. And so those are questions. My answer is going to be brief because they haven't quite figured out, because it's a policy issue. Now, when it comes to, I like how you use the term closed system, because it is. I mean, it's a single payer system, right? With the military. Now, I will say this, and for those of you guys who maybe are affiliated in some way with the military, a few years ago, every branch of service had their own hospitals, and they moved towards a joint approach. And so all the MTFs, which are the medical treatment facilities, are now, I think it's complete now, they're all under the Defense Health Agency. And so what has happened with that is this consolidation, right, of providers and services that are squarely just military. And the need, when they did that, the need actually emerged or was highlighted to collaborate with people, what they say, outside the gate. So now there is a need to share data Still definitely people that are providers, but they're in the community. They're not part of the military establishment, but they're caring for military families and service members. And so those kinds of things are being tackled because it's a need, right? And what is it like? The need is usually the engine of ingenuity, right? So the mother of invention. And so that's what they're dealing with. So for us, we actually don't have to deal with that very much because thankfully the data that is of relevance or desired, we can get it somehow, some way, but the big challenge for us, which I'm now learning from John, is very much, you collected it for services and delivery of care, and now you want to do health with it. Research with it. Okay. So we got to figure that out because it can get expensive. And it can slow down progress, right? And especially when you're talking about things that you want to maybe experiment within, one community or whatever, but you want to scale it, across the enterprise, then you definitely need to think about these things. And so those are conversations that are being had. But again, because it's not the super duper like clinical stuff, like psychotropics, medications, that kind of thing, that kind of stuff is all in one. I think right now it's called Genesis, one health EMR or EHR, and they have different compartments, but they're all part of the same system. So as long as it's for the purpose of delivering care, there is a way, but it's just when you're trying to now talk about
other uses of that
challenge. Yeah.
Let me pick up from there and ask Tammy, right? Tammy, you talked about, for you, even social media data is often associated with healthcare, right? There's a question in the chat, in the Q&A, which directly touches upon this. Let me just read this from Faika Farhatnova. The concern around ethical use of healthcare data becomes more evident when dealing with social media health data. Even though the social media data, for example, COVID-related posts or eating disorder-related posts is often public, but for research purposes, it's extremely hard, if at all possible, if not impossible, to get consent from the users who shared the data on those public platforms. How can we deal with such situations? We're not going to give you the easy questions, Tammy, right?
Let her answer it. So I think that's really tricky, and we do a lot of that work in our lab. Dr. Jessica Pater, graduate from Georgia Tech Research Institute, also worked with Margarita there, does a lot of work where she's understanding what's being communicated on social media about a disease process and then validating it clinically. And in her research around eating disorders specifically, she's found discrepancy in those two stories. And so I think maybe what Nova's posting there, Dr. Nova is posting there in the chat, is that we have to be very careful about making assumptions about any data really, but social media data, we know that if we are making assumptions about the people that are posting things, from something really extreme to someone posting about an eating disorder and they don't have an eating disorder, or posting pictures that aren't theirs, and then you're constructing a story around that can be very dangerous. And it's the truth about any data. And I would say that's my biggest concern about health data in general and how it can become biased and it can make disparities in healthcare worse, is that we may not have the full story in the data that we have in electronic health record data, for example, and that it could make things worse for people. How do we address it? We address it by doing the kind of research that we do in our lab, where we're looking at social media data. We're doing that with post-COVID patients right now. Dr. Pater is leading that work as well. And again, trying to see if there's clinical validation of the sorts of things we're seeing posted in social media context as well. But that's a tough nut to crack, really is. I think we just have to be really careful.
It is, right? And it's something which I think a lot of people need to do, research on. But that sort of goes towards the next question. We have a lot of the people that we have in the audience, right? In addition to being healthcare people, there are a lot of technologists here as well, right? And so maybe this is sort of a good opportunity for us, what kind of tools, techniques, technologies, right, would you really like to see from the technology community that can benefit the kinds of things that you are doing with healthcare data, sharing of healthcare data, making sure it gets used in good ways? Do you have any sort of, let me just say, top three on your wish list of what you would like from your technologist partners and friends here? Maybe Margarita?
In terms of tools and techniques, well, I would say, I don't want to sound like a broken record, but because of, I think, some of the aspirations that I heard be aired, let's not wait until there's a whole lot of data. Let's get more creative in applying some of these other techniques, such as data-centric AI, and to this kind of space, because it is going to be a challenge. You're never going to have all the data that you want, right? And I know, for at least in my sort of situation, getting buy-in from very different parties is part of the work, right? You have, I know, Tammy, you mentioned you're part of an interdisciplinary team. That is how you would describe and characterize your work. I would say that most of the people that I interact with, that's what they are. They may not recognize that. And so, that's like a really well-functioning, organized, sort of entity. But then we've got people that they need to collaborate outside of their core team with other disciplines and functions. And so that's the cultivating the trust. And so part of it is, we've all heard the adage, a picture is worth 1,000 words. Showing people something goes a long way towards being able to communicate more clearly what it is that you're trying to achieve and what's in it for them. That's part of, like, I'm the person that's always like, okay, so what's in it for them? Because if they're not sure on what's in it for them, they're not going to want to share data, and there's always something that's got to be articulated for all the other people. And so what I would say is, from a technology or a tactics or a technique perspective, data-centric AI being more creative around how to, we talk about, prototypes, but I actually say prototypes. I don't know if you've heard that from the human-centered community, prototypes. So it's this idea of, the point is not functionality. The point is to provoke thought. That is what we do with prototypes. And we've been wildly successful to getting people at the table that normally would not even answer the call. Because we say, hey, obviously we have to, I do the initial messaging or whatever, but it's really trying to get people at the table, because it's going to take diversity of thought to move the needle on these things, right? And so some of the techniques that I'm suggesting are much more around the human-centered approach. The other thing that I was saying, I love, Tammy, when you were speaking my language, when you talked about human-centered approach, we really do, and we have, we don't spend a lot of time doing this, but it's very important, is understanding our data personas. So when we're working with people that are teams, right, it's like, I think you were describing, how valuable it was, Tammy, to understand the roles and what they needed from the data, right? Well, you can typify that and actually, make it a persona. So you have your clinician, you have your researcher, you have your biostatistician, you have your social worker. They're all part of who's touching that patient or service member, right? What do they have to contribute and what's in it for them, right? It's ultimately what I want to gain. But in the middle, it's like, okay, I need to understand sort of what's their contribution into the whole information management process, because a lot of what we're having to deal with data engineering and cleaning data so that we can use it could have been, if we had addressed it earlier on with better information practices, we would not be necessarily having the same conversation right now around how dirty the data is, right? And so actually investing the time, some of it is qualitative research, just quick and dirty, some interviews, some focus groups, because again, we're dealing with applications that are across the world, right? So I can't talk to everybody, but I need to be able with confidence say I spoke with, or we engage a representative sample. And here's what that looks like by persona. And then we have these working groups that we'll assemble. It's like validation, yay, nay. And it's actually gone a really long way for us. So hopefully that helps. You're welcome.
Prototypes, right? A new word I learned today.
Prototype.
Prototype. John, would you like to sort of think about this question and give us your thoughts?
So when I read, was thinking about this question and thinking about, okay, so how do we make health data usable for research, and what are my wishes from the technology community? I thought my organization is supposed to be the answers to what the research community needs from the data. I can think of tons of things that would help us make that easier. I mean, I think because of but I think we're supposed to be, to a certain extent, coming up with those things. I think my concise answer is that in dealing with researchers and empathizing with their needs and their frustrations over missing data or various types of data quality issues, it goes all the way back to the originating source, and there's a long chain. And so it isn't a technology problem to say, well, we need this magical tool. We need an AI to take continuity of care documents and parse them into which would, by the way, be great. I think it's more important for us to have the research end of the chain able to communicate back to the people that are building and managing the interfaces of the originating real world sources.
A very good point. There's some interesting questions coming up in the Q&A session, right? So we can just sort of hold off on that for a couple of minutes and then come back to them. But Tammy, do you have any thoughts about your human-centric approach? And maybe you can even tie it into one of the questions that we see from Jessica Patter about, what role does digital literacy play in patients understanding what they're actually signing up for, right? How do we sort of communicate that? How do we make people know that, right? Because digital literacy, data literacy is something that is important, not just for let me say, the professional data scientists, but also for the people about, whose data it is, and the results are going to impact them.
Well, my friends are asking really hard questions on the Q&A, and you're dishing them up to me. I find that interesting. I think this is hard. It kind of reminds me of when I first started computer science, and the internet was just becoming a thing, and people were worried about privacy policies and people not understanding the privacy policies. We've been through that with mobile apps on the phones of children, and them not understanding, a child using a phone, not really understanding what they're signing up for. And I think this is the similar problem with health data, where, a patient is providing a lot of their personal, information through the electronic health record, which can be combined with other data that's available publicly to tell a story about someone. And sometimes a health system can profit from having those data and sharing those data. And there are a lot of ethical issues around that. We see this with some of the companies that collect genetic data, for example, and we're seeing that with social media companies now, where, for social scientists who study social media communication, now that's gotten a lot harder and more expensive to get access to the data. And so how do you tie that back to helping with an individual's data literacy? I think I'm going to bring it back to something the CRA promotes a lot, which is this concept of computing for all, which is really integrating computer science education from K through 12 up. So you have some kind of basic understanding of how computing works in our population. And I can't say that this is even more important now as artificial intelligence is taking hold in our world, that all of us and our children and our communities have some basic understanding of how computers work. So there's my plug for computing education. I know Georgia has a great initiative. Initiatives in Michigan have gotten killed for whatever reasons, but I think this is something we should all get behind if we're working in this field, and work with our legislators to try to push that. That's my solution. I just came up with that on the fly, by the way. Thanks, Jessica.
Margarita?
I'll add one comment. Great. That was a great answer. And thank you for setting it up. So a couple of things that come to mind as I'm listening to you, Tammy. It's a healthcare a kind of a concept as no wrong door. So at this point, there is such a need for, it's not just the patients. Honestly, I'm thinking about even the people that I work with that are social workers, you know, or providers. They went to school to provide services. They did not go to school to do data science. And yet now they're having to actually be more data curious. They're expected to ask, at least in our context, expected to be, I'm calling it data curious because it's not about reporting, right? It's about asking questions about the data. And it's a challenge, right? Where a lot of times, you know, they've been trained, and I'm talking about people that are not, they're still years away from retirement. It's the way that they were trained. So I agree with you, Tammy, you know, like initiatives that are introducing this whole idea of digital literacy. And I would even take it a step further because this is actually something that's being asked of G2I is AI literacy. So it's not just digital literacy, it's AI literacy. So now we're talking about understanding data, digital technologies, the use of AI, you know, all the things that we've touched on today, wrapped all into a nice little bundle. And so we do have courses that we're providing through the university to distance learning for professionals, especially in the context of national security and the people that we work with for AI literacy. There's an aspect to it that is more on the skills and aptitude. And there's an aspect of it that's really a mindset. And for organizations, when I talk to them, when digital comes up or AI comes up, I do tell them it's not about the infusion of new technologies only or investing on modernization and transformation. It really is about a mindset shift, a paradigm shift on how you work, how you collaborate, and how you communicate. And that has to be cultivated, and that's all of us. The last thing I'll say, and again, going back to like, this is all of us, even on this call, even if you are a technologist, right? Because it's the applications of these technologies to real world situations that also matter. It's not just building the things. And so we have G2I, I'm sorry, not G2I, Georgia Tech I think it's an institute now actually about lifelong learning. That's a thing. That's important. We all need to be, and it's across the research institute spectrum, but also our students. And it's encouraging that it's not just about the degree, it is consistent, persistent, just commitment to learning. And we're taking that also to our sponsors. We bring it to bear in our projects of like, hey, you may be a technologist, you may be whatever your expertise is, but it's the application of these things to complex real world problems. That's the rub. And so you need to constantly be cultivating ways to acquire and, you know, hone those skills.
John, you have your hand raised.
I'm trying to be polite. I just wanted to offer two, I think, concrete examples where digital literacy is relevant, but I'm kind of stretching the term because literacy implies that you're reading something and trying to understand it. And we have a different practical problem. Let me first start with the one that all of us have experienced, which is you go to the doctor and they ask you to sign the thing that acknowledges that you've been offered their notice of privacy practices. Everyone's had this experience, whether you realize it or not. I'm a HIPAA dork, so I pay attention to these things. And we're routinely asked to sign that we're acknowledging that we've been offered a thing they're not offering us. Okay, you can probably go on the website and find it. But the point is, we're not reading them. So it's not a question of understanding what it says. It's a, I'm sorry, dumb policy that it goes all the way back to Congress that wrote HIPAA that said, you know, that you have to, it's just not a practical way to communicate to the patient what's going to happen to their data. We have not solved that problem. It isn't a literacy problem. It's a, how do we communicate that information to the patient problem. The future example that I'd like to offer, and if I'm going to drop a government acronym on you of TEFCA, T-E-F-C-A. If you know what TEFCA is, great. If not, you can Google it if you're really bored later, but it's a new government-sponsored health data exchange ecosystem that is about to be, they're going to flip the switch on in a few days. And one of the primary use cases of the government is insisting be part of that is what's called individual access services, an individual's ability to access their own health data. That sounds right. But the way that the government is envisioning that this is going to happen is that we all have these phones and we're going to choose an app and we're going to point it at our healthcare data and good things are going to happen. But there's going to be a click-through agreement in that app, and we're not going to read it. And it's going to say that, by the way, all your data is going to be monetized or shared with researchers or put on a billboard on the local highway. If you don't read it, you won't know.
Very good point. So there are a lot of interesting questions coming up in Q&A. So let me just ask for one final thought from each one of the panelists before we sort of open it up to questions. If you wanted to just communicate sort of one key lesson that you have learned, right, as part of your experience and to the others in the field, what would that lesson be? John?
Yeah, I'll go first and I'll be really, really quick. Don't let anybody tell you you can't have access to data, or it's going to be too hard, or the consents are too complicated. But if you go into that, if you go down that path, be ready to be patient and persistent. It's never a technology problem. It's going to be politics and policy and contracts that are going to be most of where you spend your time.
Very nice, John. Margarita?
John took my words. It is usually not a technology problem or a data problem or pipeline problem. Although pipeline having it might help, but even then someone else will come with a creative example or a reason why they can't share their data. I would say that it really is, and it's unfortunate sometimes because with researchers, especially if you don't have an infrastructure to support you, you don't want to be spending your time doing that. Just like you don't want to be, if you're a data scientist, you don't want to be spending 80% of your day cleaning data, right? You want to be doing data science. So what I would say is it's one of those things, hopefully you are part of a team that has access to resources or people that can help you navigate those conversations because they are conversations. And it's about generating trust capital. I think we've shared, examples of ways that you can think about how to help you generate some of that trust or lower the barrier of people not wanting to even come to the table to have that conversation. So hopefully you're not too surprised that I, as a social scientist, would give you that sort of thought of like, go have a conversation. But I also realize that for scientists or researchers that may not be in your swim lane. I get that. So I would say that that is something that you'll have to look around and say, okay, who can help you have that conversation? And then the flip side, though, is true. We've seen this where doors have opened that you would normally think would not open because you found an ally and a champion. So be able to identify, what's in it for people that you're engaging, what's in it for them. A lot of times we get hyper-focused on our research aims and don't think, like, okay, this is important, but how can someone else benefit, right? And so I suggest maybe thinking about it in that perspective as well, because that's what I've learned. I've learned that data sharing is really, truly moving the needle on that is about learning to navigate a culture, learning to identify the policies and the procedures that could be helpful, or maybe where there's a gap, and maybe if none of that exists, finding someone who's willing to take a small risk, a contained risk, for the hope of moving the needle on something.
Thank you, Margarita. Tammy, you get to have the final word on this subject.
My final word is just parlaying on what John and Margarita said, or riffing on it, to not give up. And I think that the reason I'm in healthcare and I strayed from healthcare to computer science, I get back to healthcare, is because I just feel like it's foundational. We do a lot of work in mental health in my lab because it is foundational for all health data to work with and find and get access to. But if we don't take that initiative and we don't work hard at it, we're not going to solve some of our country's largest problems, which are foundational to our continued success. So keep trying.
Thank you. That's a very, very encouraging message. Thank you to all the panelists, to Margarita, to John and Tammy for a very interesting panel. Let me suggest, Helen, that maybe we can just promote everybody in the audience to be a panelist so that those of us who have questions can ask them directly and we can see who's asking, so it's more personal. So I can start by just asking questions from the, so on things. And then, so Brian Lowens asks, what about underserved communities that have limited access to those resources? Would anybody like to address that question?
I'm not sure, because it's taken out of the context of the conversation what those resources references, but I can tell you that in my world where we're trying to serve treatment and also support research, underserved communities are often served by different kinds of providers than others. And it's very important to us that whether it's a community health center or what's called an FQHC, that those organizations are participating in the data cooperative just like other organizations are, so that they benefit from access to the data, but also that their data is included in when that patient receives care elsewhere. That has the added benefit of being a more consistent data asset for research. I don't pretend to know that means that if it's used to train an AMI model, that that those populations are appropriately and adequately represented, but it's sure a lot better than if they weren't.
Thank you, John. Margarita, Faika Farhat Nova has a question directly for you. I guess she did not want me to ask that question again to Tammy. Using of smart or AI-based technologies as support tools, right? You were talking about AI-based technologies, is gaining significant traction. But despite this, there's a lack of established processes to facilitate seamless data sharing among various entities within the healthcare system and these newer technologies. So how can we enhance the optimization of data sharing and standardization processes between these different data entities?
Yeah, that's a really good question. And John may have some thoughts as well. The first thought that comes to mind is obviously FHIR as a standard. And I know I think it stands for Fast Health Interoperability something, FHIR. So Dr. John Duke, who John Kensky on the line knows very well, that he is an expert in that. So maybe for a future panel, you can have him on that. And absolutely, there is conversation. I'm sure that they are doing work around the integration and using that standard that's been widely accepted, incorporating and preparing for the proliferation of these AI technologies. That's the very first thing that comes to mind. Secondly, and something that we didn't explicitly touch on, was just this idea of working with AI ready data, like actually making it AI. And I know AI ready. I know some of the challenges that we've encountered in my context has been around data that just isn't AI ready. And what does that mean? It's all the problems that we just kind of have touched on during this conversation, but also even the volume of data, right? And so believe it or not, for some things, people have had some of the wildest ideas because sensors are much more affordable and accessible. So anything you could latch a sensor to, people are latching sensors to in the military context. Because why? They want, they want to increase their likelihood of having AI ready data. They don't even have the use cases for some of this sensor data, but they're collecting it anyway, such as like sensors on your boots. Believe it or not, because it can give them an idea on steps that service members have and other things like that. But they don't even, like, it's not actually being used, but it is being collected. That's just one example. So I absolutely, you're honing in on something. I forget who asked the question, but absolutely. And I don't know that outside of what I just mentioned with FHIR, I mean, I'm sure that there are other things, but I would look at that honestly, and I could do a quick Google search here or provide you some resources afterwards. But I do know that that is something that's being explored because it is the inclusion of new and diverse data at high volumes. John, do you have a comment?
Yeah, just FHIR. If you Google FHIR, you're going to be reading for 1,000 years. It's a very popular emerging standard based on APIs. which the healthcare definitely needs. And so I have a million, in response to that question specifically about bridging, like, for example, the EHR data and newer technologies. Standards, again, will not be the barrier. An API sounds like it would be helpful, but you're probably, depending on the set of circumstances, you're going to find, I'm sorry for being a broken record, that getting the policy and the permissions and the contracts right to allow that data to be shared will be harder than bridging the standards between those two worlds.
Thank you, John. There's a question from Isaac Hager on a new topic regarding genomic data, right? And maybe this sort of gets to the issue of privacy as well that we just briefly touched upon. Given the possibility of re-identification as genomic data is increasingly captured and detailed, is there a way to safely share this data as it becomes more relevant in personal pharma R&D? Who would like to answer that?
I kind of want to answer it by saying that's a really good question, and I don't know. If I'm even understanding the question, it's like, how do you make genetic data not identifiable? And it sounds impossible if you take it far enough. So I don't know how you solve that problem. The answer may be make sure that the consent is appropriate for the use of the data under that set of circumstances. If the consent was, we're going to use your data, your genetic data, for this purpose, and we're going to use these methods to make sure it's not re-identified, but at the end of the day, it is your genetic information. So, share or beware. Now you have a digital literacy problem, and we're back to 20 minutes ago.
Do you think there is sort of a question around policy or legal aspects that might help to complement the technology, or consent issues here?
If you're asking me, the answer has to be yes. But as I've turned in the last 35 years from an engineer into a politician and policy person, I don't mean politician in the sense that I'm running for office. I mean small p politician. The good policy is really, really hard to write. And it's a blunt instrument, okay? You got oven mitts on when you're doing policy, so you cannot do surgery with oven mitts on. So if you want a very specific, you want to protect the world, the country from a very specific abuse of data or privacy issue, it's hard to do that with policy and do it well.
Thank you, John. Tammy, did you want to take a crack at
Well,
that?
I was just going to go back. Yeah, I was just going to go back to something John said earlier about, digital literacy and really empowering people instead of this, HIPAA compliance thing we're signing off on that we don't even read. Really, forcing corporations that collect these data to communicate effectively, not in some, very like hidden, just check it off the list way. And that might be a better way of tackling the problem, empowering individuals. And not everybody's going to take advantage of that, but I think that's the best hope.
Tammy, you just reminded me that I saw an announcement from the ONC, which is a branch of the federal, an office of the federal government, saying they want to put like nutrition label equivalents on AI models, which I think is if they can do it well, it's a good idea. So at least it would have to say, how was this model trained? On what data was it trained? And other relevant information, because it's a lot more practical than expecting everybody to read a thing and understand it. It's a lot more practical to put out for the privacy zealots who will read that thing,
right?
Something that says this model was trained in this way, and it only takes one privacy attorney to read that and go, that ain't cool, to mitigate the problem.
Thank you, Tammy. Thank you, John. Margarita, do you have any thoughts on that you would like to share?
No, I don't have any thoughts on that.
Very good. So let me thank the panelists again. Helen, if you can put up the final slide of the slide deck, which points people to the survey, and we'll of course reach out to all the people who attended. So there is a QR code there. if you would like to take a quick survey, please point your, mobile phones at that QR code. Helen, I think will we also be able to share this with other attendees who may have left already?
Yes, I'll make sure to send it out.
Very good. So again, I'd like to thank all our panelists for a very engaging and a very informative discussion on these topics. So if anybody in the audience would like to stay on for another 5 minutes or so, or would like to be able to share their views on something, we'd be very happy to promote you as a panelist. Please indicate that in the Q&A.